A senior leaves the hospital needing rehabilitation. Their Medicare Advantage plan says no. The family appeals, and suddenly the answer changes. In a federal review of skilled nursing admission requests, insurers reversed 95% of the denials the patients or providers appealed. 95%. That does not prove an algorithm caused the original denials. It does prove the system got questioned and then changed its answer at an extraordinary rate. Now, Congress wants records from UnitedHealth, Humana, and CVS Health to learn how algorithms, predictive tools, contractors, and employees shaped those decisions. The real mystery isn't just why so many denials were reversed, it's what happened to everyone who never fought back. Here is what the Health and Human Services Inspector General actually measured. In June of 2024, 19 Medicare Advantage organizations processed about 109,400 requests to admit patients to skilled nursing facilities. These are short-term medical and rehabilitation settings after a hospital stay, not simply long-term custodial nursing homes. The plans denied about 13,500 requests, or 12.3%. Patients and providers appealed only about 18% of those denials. Among that small group, insurers overturned 2,313 decisions. That's 95% of appealed denials. The Inspector General called the rate extremely high and said it raised concerns about whether the initial decisions were accurate. But the report also included an essential limitation. The data alone could not determine how many original denials were inappropriate. Some appeals may have included new medical information or reflected a patient's changing condition. Now put the two numbers together. Here's the truth bomb. Only 18% appealed. 95% of those appeals won. The people who challenged a denial entered a process that often reversed the answer. But more than 4 out of 5 denied requests never entered that process at all. The Inspector General said those patients may have accepted a lower level of care, paid for skilled nursing themselves, or gone without the recommended care. And an appeal is not instant. Initial approvals were generally decided the same day. The median path from the original request to an appeal decision took 6 days. 17% took 10 days or longer. For a recovering senior, 6 days is not an administrative abstraction. It's 6 days while a hospital tries to discharge you, a bed may disappear, muscles weaken, and a family scrambles to learn rules they never expected to need. A successful appeal is better than a final denial. But a system that makes frail patients win a paperwork contest before receiving rehabilitation is not frictionless care. The company-level numbers make the congressional question sharper. UnitedHealth Group denied 12.9% of sampled skilled nursing admission requests. When those denials were appealed, it overturned 1,022 and upheld 3, a 99.7% reversal rate. CVS Health denied 13.5%. It overturned 375 appeal denials and upheld 7, 98.2% reversed. Humana also denied 13.5%. It overturned 619 and upheld 53, 92.1% reversed. Then there is naviHealth, an indirect, wholly owned UnitedHealth subsidiary that processed about half of all requests in the review while also working for multiple insurers. It denied 14.3% of requests. Of its appealed denials, 96.6% were overturned, 97% when rounded. Those are not industry-wide annual rates. They are skilled nursing admission results from 1 month for the organizations the Inspector General reviewed. That distinction matters. Still, when 3 of the country's biggest insurers reverse most appealed denials in the same category, asking how the original decisions were produced is not speculation. It is oversight. So, where does artificial intelligence enter the story? A prior Senate investigation reviewed roughly 280,000 pages of documents. It reported that UnitedHealthcare's post-acute denial rate rose from 10.9% in 2020 to 22.7% in 2022 as the company increased automation. It also described a work group exploring machine learning to predict which denials were likely to be appealed. At CVS, Senate investigators said a tool called post-acute analytics used artificial intelligence to help reduce skilled nursing spending. They also found that the volume of prior authorization requests grew faster than enrollment during the period they examined. Humana has contracted with naviHealth since 2017, but the Senate report said the evidence it reviewed did not establish the full extent of Humana's use of automation or predictive technology. UnitedHealth says its artificial intelligence models do not make coverage decisions or adverse determinations. The companies have said final denials are made by people, and all three have announced reforms intended to simplify prior authorization and speed electronic decisions. Those positions matter. So, does the unanswered question, if a human signs the final decision, what recommendation, score, predicted stay, or workflow appeared on the screen before that signature? That is the question Congress is now trying to document. In Senate testimony, Margaret Bent described her family's repeated fights to obtain rehabilitation care for her father, Gary. Her account is one family's experience, not proof about every case. But it shows what the burden looks like from the other side of the portal. The patient is sick. The family may not know the difference between a coverage rule, a medical necessity test, and a contractor's recommendation. They may be told the hospital is ready to discharge, while the insurer's answer is still no. Every appeal demands time, documents, clinical support, persistence, and often someone healthy enough to do the fighting. That creates a selection problem. The 18% who appealed are not necessarily representative of everyone denied. They are the people who could navigate the process or had a clinician or family member who could do it for them. The 95% reversal rate is shocking. The 82% who did not appeal may be the more important number. Medicare pays. Medicare Advantage plans a fixed amount per member. That structure is designed to reward coordinated, efficient care. It also means that more expensive settings affect a plan's costs. In original Medicare, average spending in 2023 was roughly $16,000 for a skilled nursing stay, $24,000 for inpatient rehabilitation, and $49,000 for a long-term care hospital stay. Home health averaged about $6,000. A cost difference is not proof of a wrongful denial, but it explains why utilization management has enormous financial consequence and why its guardrails matter. Medicare's rules allow algorithms to assist coverage decisions. They do not allow a plan to replace an individual patient's medical history, physician recommendation, and clinical notes with a prediction drawn from a larger data set. A predicted length of stay by itself cannot end post-acute care. The patient must be reassessed. CMS proposed additional artificial intelligence protections for the 2026 plan year, then did not finalize them in that rule. Existing individualized decision requirements still apply. The line is clear in principle. Technology may organize evidence. It cannot become the evidence. On July 15th, Senators Richard Blumenthal and Josh Hawley announced new records demands to UnitedHealth, CVS Health, and Humana. They asked for post-acute care policies, appeal outcomes, staffing information, contractor records, complaints, and the names and uses of algorithms, software, and artificial intelligence systems from 2023 forward. In other words, Congress is not only asking whether a person clicked deny, it is asking what system assembled the case, what the system was designed to optimize, what limits were placed on it, and how often its output aligned with decisions later reversed. Until those records are evaluated, the honest conclusion is narrow but powerful. The reversal pattern is established. The algorithmic cause is not. If a Medicare Advantage plan denies rehabilitation care, an appeal can matter enormously. Ask for the denial in writing. Ask the treating clinician to document why the setting is medically necessary. Pay attention to expedited appeal rights when delay could jeopardize health. But do not confuse a successful appeal with a successful system. 95% reversed means the appeal door worked for many people who reached it. Only 18% reaching that door means the burden was never shared equally. Should insurers be required to disclose every algorithm that touches a coverage decision? Tell me where you would draw the line. Subscribe for sourced investigations into where artificial intelligence meets real life. And next, watch how Amazon spent $100 billion on AI while another part of healthcare, the local pharmacy, was disappearing. The question is no longer whether software participates in care decisions. It's whether the public can see what role it played before a senior hears the word no.